All right, let's dive right into part 10, clinical management, surviving sepsis, Hour-1 bundle, and acute treatment protocols. Today, we're tackling the absolute most urgent clinical reality of sepsis, and more importantly, how we, as revenue integrity and CDI professionals, actually validate it in the medical record. We're moving straight from theory to the bedside, zeroing in on the surviving sepsis campaign's Hour-1 bundle and those acute treatment protocols that literally save lives. So the very first thing we need to establish and honestly keep front and center during any chart review is this undeniable fact: sepsis is a medical emergency. The clock starts ticking the literal second a patient presents with a dysregulated response to an infection. Whether they're in the ER or the ICU, every single minute counts. As auditors, when we see a sepsis diagnosis, we should instantly be hunting for that corresponding urgency in the provider's orders and interventions. To really grasp the treatment protocols we're diving into, we've got to set the clinical stakes using the authoritative standard from 2016, the Sepsis 3 consensus. Remember, this completely tossed out the old SARS criteria. Today, sepsis is strictly defined as life-threatening organ dysfunction caused by a dysregulated host response to an infection. And septic shock? That's a specific subset where the patient has persisting hypotension requiring IV vasopressors to keep their mean arterial pressure, or MAP, at 65 or higher, and a serum lactate level greater than 2, despite getting adequate fluid resuscitation. That is exactly the clinical picture we're looking for. Here's our roadmap for today. First, sepsis, a medical emergency. Then, the Hour-1 resuscitation bundle, followed by source control and organ support. Then we'll hit the CDI chart audit significance and wrap up with our conclusion and next steps. Let's transition from high adrenaline clinical action directly into our chart audit evidence hunt. Sepsis, a medical emergency. Our story starts right on the front lines, the ER or the ICU. This is where just the mere suspicion of sepsis has to trigger an immediate, time-critical set of interventions. The whole philosophy of the Surviving Sepsis campaign is basically summed up in one rule: initiate the bundle upon recognition. It is a literal race against time to stabilize the patient and drop that mortality rate. So think about it from an auditing perspective. If a provider documents suspected sepsis, but then, waits 12 hours to order labs or antibiotics, well, we've got a huge clinical and documentation disconnect. The documented acuity has to match the urgency of the treatment. Section 2, the Hour-1 resuscitation bundle. Let's break down the exact sequence of evidence-based interventions the physician is expected to execute within that very first critical 60 minutes. This 5-step sequence is the absolute gold standard of acute sepsis care. Step 1, measure the serum lactate. Step 2, get blood cultures. But crucially, do this before giving any antibiotics so the cultures aren't compromised. Step 3, hit them with empiric broad-spectrum antibiotics. Step 4, start rapid administration of 30 milliliters per kilogram of crystalloid IV fluids. And Step 5, apply IV vasopressors if they're still hypotensive. Let's look a little closer at the specific clinical triggers embedded in these steps. Notice that specific threshold? Greater than 2 millimoles per liter. Lactic acid is just a byproduct of anaerobic metabolism, so normally it's below 2. But when a patient has tissue hypoxia and hypoperfusion, which are classic signs of a dysregulated response, that lactate shoots up. An initial level over 2 is classified as hyperlactatemia. In the Hour-1 bundle, that's a strict trigger for the provider to remeasure it within a few hours to see if tissue perfusion is actually improving. But what if that lactate hits 4 or higher? Now the stakes are incredibly high. At 4 or above, we're looking at severe lactic acidosis. Per the guidelines, a lactate this high or the presence of frank hypotension absolutely mandates Step 4, that rapid, aggressive dump of 30 milliliters per kilogram of IV fluids. This volume resuscitation is critical, and honestly, it's a massive green flag for us auditors when we're trying to validate high patient acuity. Now, what happens if those rapid fluids just don't stabilize the blood pressure? If the patient is still hypotensive during or after that fluid rush, Step 5 kicks in. IV vasopressors are applied to keep that mean arterial pressure at 65 or higher. Like we learned from the Sepsis 3 definition, this persistent need for pressors paired with an elevated lactate marks the dangerous transition into true septic shock. Section 3, source control and organ support. Because beyond that chaotic first hour of resuscitation, providers have to actively eliminate the root cause of the infection and support systems that are actively failing. This is what we call source control. Listen, you can pump a patient full of the strongest antibiotics on earth, but if you don't physically remove the active nidus of the infection, they aren't going to get better. As CDI professionals, you should be scouring those operative and nursing notes for physical removal techniques, surgical drainage of abscesses, pulling infected central lines, taking out Foley catheters or peripheral IVs. These procedural interventions are incredibly powerful clinical indicators of a severe active infection. At the exact same time, the provider has to manage organ dysfunction. While they're supporting these failing systems with oxygen, ventilation, or renal replacement therapy, you need to memorize these specific lab thresholds. You're hunting for a PFR ratio under 300 for respiratory failure, a creatinine jump of more than 0.5 from baseline for renal failure, or maybe a platelet count dropping below 100,000 for coagulopathy. When you see these lab values right alongside treatments like IV fluids and pressors, you've just painted a complete, undeniable clinical picture of sepsis. Section 4. CDI Chart Audit Significance. Okay, let's pivot away from the clinical adrenaline of the bedside and focus on the analytical rigor of the CDI auditor diving into the medical record. We really have to address the gap between clinical medicine and coding roles. Clinical documentation is the provider's written statement that a condition exists. Code assignment, on the other hand, is the translation of that statement, independent of the clinical criteria. The huge caveat here is that a coder cannot just independently assign a code because they saw some crazy lab values or bundled treatments. They legally need the provider's explicit written diagnostic statement. To really drive this home, look at the official ICD-10-CM guidelines, section IA-19. It explicitly says that code assignment is based on the provider's diagnostic statement, not on the clinical criteria used to establish it. This highlights exactly why teamwork between the provider and the coder is absolutely essential. If the provider writes sepsis, the coder codes sepsis. But if an insurance auditor looks at that chart and sees no Hour-1 bundle, totally normal lactates, and zero organ dysfunction, that claim is absolutely getting denied for clinical invalidation. So as an auditor or CDI specialist, your job is to proactively bridge that gap through your evidence hunt. You're using these treatments as structural indicators. You verify those initial lactate draws and remeasures. You confirm blood cultures were actually drawn before antibiotics. You map that massive 30 mL per kilogram fluid bolus directly to the patient's hypotension or severe lactic acidosis. You track the vasopressors to make sure they were linked to a MAP under 65. When you do all of this, you confidently validate that the provider's diagnosis of sepsis or septic shock is clinically supported and, frankly, bulletproof against denials. Section 5. Conclusion and next steps. We have covered an immense amount of ground today. We've seen exactly how the rapid, life-saving logic of the Surviving Sepsis campaign and the Hour-1 bundle translates directly into the concrete evidence we need for accurate, compliant coding. But let's be real, knowing the rules is only half the battle. How do you uncover this evidence when the chart is an absolute mess? When a patient has a UTI, diabetes, and suspected toxic shock syndrome all happening at the exact same time? The real test is in the messy, real-world charts. Stay tuned for Part 11, where we analyze real-world clinical case studies, putting these SOFA scores, lab values, and diagnostic rules into practical chart review. Until then, keep learning and keep leveling up. This is Decode Healthcare with Herschel.